So hi everyone, and welcome to Corinne and Joe's video presentation here of constraint-induced movement therapy, or CI therapy. And really just the focus of this video is just so we can get a little bit more visual component of some of the inclusion criteria that we'll need to do, some of the specific activities that might be involved, or just discussing the activities that we would use within the therapeutic approach, and then what are some general outcome measurement tools, or how would we monitor progress with that. So when we recall that CI therapy is mostly geared towards individuals with mild to moderate hemiparesis. And with that being said, the primary and original protocol for that, for the inclusion criteria, required an individual to be able to engage in 20 degrees of wrist extension. So I already have a goniometer here set at 20 degrees. So if we line this up here, and that right there is about 20 degrees of wrist extension. So if I go back to neutral and then back up, so we're looking at being able to do about like that movement right there. And then also too, 10 degrees of extension of the MP and the IP joints. So we're looking at, slight extension of each digit it actually called for. So, and then also to be able to do that 3 times within a 1 minute time frame. So if we could at least engage in that 3 times within a 1 minute time frame, that would be part of the inclusion criteria. And then other aspects is to be able to stand with or without assistance for 2 minutes, and then also to transfer from basic areas and have minimal cognitive deficits and minimal pain and spasticity. So really those are the main features for inclusion criteria. There have been a little less lenient criteria set within the literature that's been researched that they've shown efficacy for, and that's 10 degrees of wrist extension. So we're looking at, instead of going up a little bit higher, we're just minimal movement here. And then also 10 degrees extension of just 2 digits at the MP and the IP joint. So anyways, that's a little bit more lenient, but they would still need to qualify for those other factors that we just discussed. So, and we're going to need a goniometer for this, because we're going to need to take these measurements to make sure, and I'm sure an experienced therapist could probably take an eye measurement of that a little bit better, but for that standpoint we need to do that. And so it's proposed that approximately 25%, potentially up to 75% of individuals would be able to be included or meet the criteria for that we just mentioned. So, so some of the basic techniques that we emphasize. So technique number 1 is really that repetitive task-oriented practice of the impaired upper extremity. So what I'd like everybody to do is go ahead and put your sock on your dominant arm and hand. Mine is my right, so my left hand and arm is my left dominant, so I'm going to be using this. And then, just kind of get a feel for moving some objects around with this. Obviously, we're at a much greater advantage because we do not have neurologic injury with that. Maybe we're a little less coordinated because we haven't used that as much, but at the same time, too, it feels a little different, And so really there's that repetitive task-oriented practice, and as I include within the PowerPoint slides, really how the therapist would administer this is in successive approximation. So if an individual has very limited movement of that upper extremity, we're just going to be trying to work and build upon what they can do. So some of it might be quite minimal at first, and with goals just to reach further or be able to point or touch something. And then it might go to stacking blocks. I realize that's not occupational based in many ways, but at the same time it's kind of build that foundation or scaffolding. And the therapy would be administered typically in sets of 10, so we do 10 sets of 30-second activity duration. So, and there would be breaks in between, and so that's the shaping component. Sometimes a therapist will provide hand-over assist depending upon if that's needed. Then also too, they will specifically look at certain angles of the joints, what body parts or moving through the range of motion more readily than others. So then they can kind of target each of those areas for specific tasks, because really the goal is to try and remediate as comprehensive of a function as possible here. And then eventually be able to transfer these into more specific tasks, such as maybe folding clothes. Maybe we'll be eating with our left hand, just bringing a spoon or a fork from plate to mouth. And Other activities could involve playing games, pushing a broom, brushing our teeth. I think that's an excellent one. Putting on makeup, combing our hair, etc. And the interventress or the therapist and then participant interaction is really critical too. So positive reinforcement is really a key. So once again, we're talking here about repetitive, task-oriented practice of the weaker upper extremity. So, and kind of like to complement that is the other technique, which is the restraint of the more functional upper extremity. And typically it's done either in a sling. I think that's what's oftentimes most acquainted with CI therapy is somebody's arm in a sling while they're doing some activities, but oftentimes a hand mitt, padded hand mitt, is used as well. Now that does permit the upper extremity to more freely move around and potentially help out in some ways with transfers, etc. That's part of the reason why they use a mitt, because then you can use your arm if you want to transfer out of the chair, etc. Or your good arm, I should say. I wouldn't be using my left arm. But then at the same time, though, too, then you're really not, I guess it could be argued whether you're focusing on that left upper extremity as much, but as long as you keep the task towards it, then you would be. So, and this would be constrained either 6 hours or up to 90% of the waking day, and then our activities that we're going to be doing with our weak arm are either going to be between the original protocol calls for 6 hours a day, so that's quite a lot. But the modified approach, which has shown efficacy in the literature, is as little as 2 hours per day. Around 3 hours or 30 hours total for the activity duration in general across the 10 to 15 days is demonstrated, I think, the most efficacy. So, and then the last component, trying to really reinforce and then promote the successful completion of this activity. So once again, it's going to be anywhere between 2 to 6 hours a day that the individual is going to be engaged in a therapeutic process or using that paretic upper extremity. And then the good arm is going to be constrained up to 90% or 6 hours of the day. And then the therapy is going to last anywhere between 10 to 15 consecutive weekdays. So with that being said, that's a pretty intense regimen, and there's a strong behavioral component integrated within the program to try and help individuals be successful through that. And those include completing a home diary. Another one is the motor activity log, and this is what I just showed you here earlier and what we're going to print off when we go through the activity here, etc. So pediatric cerebral palsy, the protocol for administration is quite similar. So with that being said, that's might be modified for certain more task-oriented activities that are geared towards children's play, etc. But that's going to be quite similar in a lot of ways. Outcome measurement, so the motor activity log can be used by both therapist and participant on a daily basis. And if we, you can get this right off from the University of Alabama Birmingham's website, along with many of the original research articles conducted by Edward Taub in his lab. And then of course there's a vast array of other research that you can find, either just doing a Google Scholar search or going on GVSU's website. But if we turn to page 14 here, and as I try and use my left arm here too as much as what I can, so amount scale. So really our scale here for the motor activity log is how much did we use it and how well did we use it. So frequency, how much, and what was the efficiency of that. So we see some activities on here, brushing teeth, putting on makeup, writing on paper, carrying an object, eating. So these are all activities that are on this motor activity log. Then that would be scaled by the individual at the end of each day. And there's more simpler activities too, such as opening a drawer, picking up a phone, wiping off a kitchen countertop, opening a refrigerator, etc. Now there's specific administration procedures for the MAL in general, as the therapist administering it, but for the filling out the actual score sheet for the participant side, it's not as complicated. So I'm not really going to go into those specific procedures there. But and the scale goes from 0, did you use your weaker arm at all, or 5, then you used your weaker arm as often as before the stroke. So that's once again frequency or amount. And then how well. A 0 score would be the weaker arm was never used at all. And then number 5 is the ability to use the weaker arm for that activity was as good as it was before the stroke. So I'd like everybody to do real quick is if you have a pencil, you try writing your name and cursive or print, however you do it, on the sheet of paper real quick. Try writing my name here. So, I was able to do it, but not super great. Not nearly as great, and if I had to write faster, that would be an issue, but anyways, at the same time, that's more of a lack of coordination as opposed to intact neurological neuromotor components in my brain anyways right now. So with that being said, what I'd like to challenge you guys is to, doesn't have to be done right now, but before you go to bed at night, brush your teeth with your left arm, or your non-dominant arm I should say, either right or left in that respect, or eat with your fork or your spoon the complete dinner, and try and have your right arm restrained in some way to while you're doing that, so that there is no, I guess, cheating per se in that regard, or putting on makeup, etc. So pick two activities to do. A lot of these are simple ADL or IDL tasks, and excuse me, and then both Corinne and I have just a couple of quick reflective questions on the discussion board that we would like you to try out, just to kind of give your perceptions and then your overall, just in general experiences regarding that. So, all right, have fun.